All right, everybody, please direct your attention to the very west portion of 250 or your closest monitor. We are going to begin. May I have a volunteer to have your cranial nerves checked? Christine, right? Come on up. All right, have a seat. So before we begin, let's go over a few things. Contrary to information you might get or in the future or you may have received in your, can everybody hear me in 270? All right, so contrary to information you may get in future classes or past classes, your cranial nerve exam, while of premium importance, is not, I repeat, not going to be a set of procedures that you're going to be doing every single day on every single patient. So I want to make that crystal clear. So my next question is, when would you do these? When would you say, okay, I need to do a cranial nerve exam on this person? Say again, please. Okay, if you saw a visual inspection of a sluggish group of facial muscles on one side compared to the other, that's a very good reason. What else? Okay, maybe there's a lazy eye. Maybe you're examining Biggie Smalls before he got shot. It was all a dream. I used to read What Up magazine. Very good reason. What else? How about I can't smell? How about I can't taste? How about I'm seeing blind spots? How about I have headaches? These are all very good reasons to examine the cranial nerves. What is not a good reason? Well, my foot hurts. You patients coming in with a low back or radiculopathy with sciatica. That's another thing your mom lied to you about. There's no reason, unless they have those complaints, there's no reason to waste time doing your cranial nerve exam. Everybody got that? Question? Okay. So I know it's hot in here. I know it's hot in here. I'm just going to leave it at that. What was I saying? So cranial nerve exam, while very important, is also pretty straightforward as long as you have a pretty good idea about what the nerve is and does. For instance, cranial nerve 1, olfactory nerve, is primarily responsible for a special sense of smell. Everybody should know that. So we're going to save that exam for probably week 13 because it can get a little messy, and I want you to make sure to have time to acquire your proper sense. And of the cranial nerve exams, that's the one that's probably done the least. In fact, I've seen exam forms where today I can consider myself the luckiest man in the face of the earth. That's from Pride of the Yankees. The echo. Never mind. Sorry about that. So I've seen exam forms that list the cranial nerve tests, and the olfactory nerve, special sense of smell, isn't even listed there. So we're going to save that for week 13. And we're going to start with cranial nerve 2 and work our way down. So cranial nerve 2, what is it good for? Absolutely nothing. Obviously, we're talking about special sense of sight. And we're also going to be looking at visual acuity. We don't have any Snellen and eye charts or the equivalent in this particular building. So I'll step you through the proper procedure in order to do a Snellen and eye chart for visual acuity in the lecture component. So we're going to start with tests for cranial nerve 2 with the pupillary light reflexes. And I'm going to demonstrate this in a proper, viable manner. And this may be a little different than what went on in the IPA series, but I'm going to stress specific details that I think are very important and explain why. Sound good? Okay. Hello, Christine, I'm Dr. Baudet. What I'm gonna have you do is remove your glasses. And what I'm gonna do is I'm gonna shine this light into your eyes. I'd like you to keep your head still and keep your eyes open. And I'm gonna shine the light in your eyes. Just sit there and relax and breathe normal. But before I do that, if there is a side of complaint, which side do you examine first? The uninvolved side. And my next question is, why is that? Because I want to see what the patient's closest semblance of normal is before I move to the side that's affected. So that's going to be at any time there's a test that can be done bilaterally. One of the provisions on the rubric for performance is that you start on the uninvolved side if we give you a side of complaint. If your only goal in life is to accumulate as much points as possible and you don't care about the clinical ramifications, then you're going to be very frustrated if you perform it on the involved side first. Make sense? Okay. So complaints on the right, we're going to start on the left in the case of Christine. What I'm going to have you do is I'm going to have you take your hand, put it in front of your face like this. And what I'm going to do is I'm going to shine light in each eye. So just relax and breathe normal. Want to do every test bilaterally and start with the uninvolved side first at all times. Pupillary light reflexes, patient seated. You need a viable light source. If your light doesn't work, it's going to be a waste of time for you and the patient. So do you have to use a pen light? I saw a few people using rotoscopes, which is like, okay, I guess. Pen lights are not that big of an investment. And when I say not that big, I mean infinitesimal. The word of the day is infinitesimal. You don't have to do this. Okay, right eye. Shine the light in the right eye. Look for the pupil to constrict. Shine the light in the right eye. Look for the left eye to constrict, more specifically the pupil. So would you like to know what I saw? No pun intended. Would you? What I saw was Christine's pupil constricted right pupil constricted when I shined on the right, and the left pupil constricted when I shined in the right. Additionally, when I shined in her left, I saw the left pupil constrict and the right pupil constrict when I shined it again. Is this a normal or an abnormal test? The answer is it's a normal test. So what's an abnormal test? An abnormal test would be you shine the light in one eye and either one eye or both eyes do not constrict. There is neither a direct nor consensual reflex when you shine the light in one eye. So what are the reasons for that lack of pupillary constriction? Okay, so I'm hearing cranial nerves 3. So if in fact it was an oculomotor nerve damage, let's say on the right, what would be the pattern of lack of pupillary constriction? All right, think about it in these terms. Let's talk about a normal reflex. You shine the light in the patient's right eye. What's happening is sensory afferent nerve through the cranial nerve 2 optic nerve is going inside and creating a bilateral involuntary constriction of the pupils. What muscle constricts the pupils? Crickets. Orbicularis oris, no, thank you. But thank you for playing. You got most courage of anybody here. Orbicularis oculi, the answer is no, but thank you for playing. You got courage as well. The muscle that constricts the pupils are called the ciliary constrictor muscles, innervated by oculomotor nerve. So therefore, I'll go over the main rules of Baudet's lecture and lab classes tomorrow in lecture, but devices making noises is very irritating for me. Anyway, so if there is a lack, let's do a scenario. If I shine the light in her right eye, or excuse me, left eye, and I did not see a left-sided pupillary constriction, and then I looked on her right, shined it again, I did not see a right-sided pupillary constriction, then how do you explain that? So here's the scenario again, and you're half right. Here's the scenario again. I shine the light in the left eye. I do not see a direct reflex on her left. I shine the light in her left eye. I do not see a consensual reflex on her right. Okay, so that's correct. But essentially, let's keep it in layman's terms before we get too technical. Information is just simply not getting in to cause a involuntary constriction of the pupils bilaterally. So we know that there's a problem with the sensory afferents, in this case, optic nerve on the left. Everybody got it? I got a million of these. Let's do another one. I shine the light in Christine's right eye. I see a direct reflex on her right. I shine the light in her right eye again. I do not see a consensual reflex on her left. Where's the problem? So information was getting back out on her right, but it was not coming out on the left. So therefore, there's a problem with motor efferents on the left, in this case, left-sided oculomotor. So the pattern of constriction or lack thereof will help you determine where the nervous irritation is. Everybody got that? All right, so let me add a wrinkle. We talk about cranial nerve lesions a lot in this class, but what do I mean by that? What is actually putting pressure on that particular nerve that's causing this dysfunction? What might have happened? Okay, so I assume you're getting at stroke. So could a transient ischemic attack in just one specific area cause very specific nerve damage? The answer is possible, but it's unlikely. Mainly, and you're probably thinking head trauma. Well, repeated head trauma, if it's low enough, I don't mean to hit her or anything, but if repeated head trauma basically to the base of the brainstem would probably affect more than one cranial nerve. So, okay, pressure on the pituitary. You're getting warmer. So what's putting pressure on the pituitary? Okay, so he's talking about the pituitary gland. If there's a pituitary adenoma and it's getting very large, it might irritate the optic chiasm, which could cause visual disturbances, but the other cranial nerves probably wouldn't be affected based on the position of it. So most likely when we're talking about cranial nerve damage, we're talking about gradual symptoms due to a slow growing tumor, either benign or possibly tragically malignant. Make sense? And later on, I'll be talking about acoustic neuromi, which sadly are almost asymptomatic until they're affecting multiple cranial nerves, including 7 and 8. So that's one example of a lesion. But basically, there's irritation to these cranial nerves. And I just showed you the pattern of how to figure out which one is the problem or causing the problem. Pupillary light reflexes. Any questions? You have to have had some question about how I did this. Like, for instance, why did I have her put her hand in front of her face? Just for the heck of it? Go ahead. Right. So if I didn't do that, she could be completely blind in the left, but some of those light particles may have migrated to the right and caused a consensual reflex on the left, which would basically be a false negative. So that's why we're going to ask you to have the patient put their hand in front of their face in order to shield it. Let me ask another question about my performance. Why did I shine the light in her eye twice in both eyes? So if I didn't, and I just simply did the following, and keep in mind, when you're watching me, this is completely wrong. I'm going to do this completely wrong, and I want you to watch me very carefully to see what I'm doing wrong. Like, don't do that yet. Hi, I'm Dr. Burdett. I'm going to be shining the light in your eye. Now I'd like you to put your hand up in front of your face. I'm going to shine a light in each eye. Keep your head still and your eyes open. Want to do air test bilaterally and start with the uniball side first at all time. Is that painful at all? Positive finding equals lack of pupillary constriction in one or both eyes, and it could be due to oculomotor or optic nerve damage, depending on whether one eye or both eye did not constrict. Yay! I aced it. Give me my points. What did I do wrong? I didn't do it twice on each side, but most importantly, I didn't assess for a consensual reflex on either eye. So what I would like you to do or get into the habit of doing is hand up like this. Position yourself in a vantage point where there's no doubt when we're evaluating you that you're looking for the consensual reflex. For instance, there I'm looking for direct on her left, and here I'm looking at consensual on her right. Now, this is technically wrong too. Watch very carefully. Dr. Burdett, when you're shining light in your eye, could you put your hand up like this? I'm going to do everything just bilaterally and start with the on-ball side first at all times. Any pain with that? Positive finding is lack of pupillary constriction in one or both eyes, and it could be due to optic nerve damage or oculomotor nerve damage, depending on one or both constricting. I shined it twice in both eyes this time. Give me my points. What did I do wrong? I didn't look at the opposite eye because she had her hand in her face for that consensual reflex. You see that? No pun intended. Actually, it was a little intended. Pupillary light reflexes. That's pretty much all there is to it. Let me ask you this. Suppose there was left-sided oculomotor nerve damage causing a lack of consensual reflex. What did I say, left? Left oculomotor nerve damage resulting in a loss of a left direct reflex and loss of a left consensual reflex. What do you suppose would happen if I went ahead and checked for accommodation from far to near vision? So let's talk about accommodation from far to near vision first before we talk about abnormals. What should normally happen? Both let me just do it first and then we'll explain, but you're on the right track. How you doing, Christine? I'm Dr. Burdett. I'm just going to be checking your vision. I'm just going to ask you to pull focus on my pen light at the right time. So what I'd like to do first is kind of look at my friend, the skeleton over there. Keep your head still. Keep focusing, keep focusing. I'm going to put my pen light in front of your face. Keep focusing on the skeleton, keep focusing on the skeleton, keep focusing on the skeleton. Now look at my pen light. Is that painful at all? Okay. It was kind of hard to see in the monitor. So let me explain what I saw. I saw both eyes adduct, and I saw both pupils constrict. Is that positive or negative? The answer is it's negative. So why did her eyes, both of her eyes adduct, and why did both of her pupils constrict? Because her oculomotor nerve bilaterally is intact. Oculomotor nerve innervates medial rectus, as well as we already determined the ciliary constrictors. So if all of that is working, then there's going to be convergence, there's going to be constriction, and there's going to be convexity of the lens, which we can't see. Those are the 3 C's of normal accommodation: convexity, convergence, and constriction. Make sense? So let's go back to the other scenario. If left-sided oculomotor nerve was positive, and most likely the indication on the pupillary reflexes, then what would you expect to happen on this test? There would be no convergence, there would be no medial rectus action or less of such on the left, and there would be no pupillary constriction on the left. It all has to tell the same story. I'm not going to trick you. If your diagnosis that you have to ferret out is a left-sided oculomotor nerve damage, then both tests will be positive. That's a textbook clinical scenario that I'm going to give you in this class. When you get in practice in clinic, all bets are off. They could have all sorts of haphazard abnormal findings. Does that make sense? But in this class, I'm not going to trick you. Make sense? Any questions on accommodation for part of near vision? Now, surely, and I know I'm not Shirley. I know you're not Shirley. Surely, I did this procedure a lot different than you were taught in the IPA series. What were you taught in the IPA series? I know what you were taught in the IPA series, but you focus on my pen light. I'm just going to bring it in, keep focusing on the pen light without moving your head. Is that painful? So can you do it that way? The answer is sure. I don't like it as much, and the reason being is it's harder for me to see the pupillary constriction. I like to see a more dramatic response. I don't care if you do it either way, but just know that I've been to I've been to Colorado with the national boards, and I've talked to other faculty, bless you. I've talked to other faculty that are adamant that you can't assess accommodation from far to near vision by doing this. And he was just so mean and adamant that I didn't want to argue with him, but I thought, well, why not? Anyway, let's go back to cranial nerve 2. While confrontation is not really a test for cranial nerve 2 per se, it will help you identify blind spots in the patient's vision. So I'm going to do that really quick, and then we'll take a break if you're dying here. Okay, Christine, what would like Jane? Can I borrow that chair? Thanks. Have a seat right here. All right, I'm going to be assessing how well or how poorly you can see. So what I'm going to ask you to do is put your place on the right. We're going to start on the left. What I'm going to have you do is put your right hand and cover your right eye. What I'm going to do is I'm going to get at eye level, and I want you to tell me, keep your head still. Look at me, and I want you to tell me when you can see my fingers and when they go away. Tell me when they go away. Oh, let me start over. I did a big boo-boo. $20? Get out of here. So doctor needs to cover the opposite eye. So you're checking the temporal versus the nasal and superior to inferior. I did not do that. I apologize. I apologize for the confusion. Ready? Same deal. Okay, so tell me when you can see it. Okay. Tell me what they will. Okay, same deal. Want to do it just bilaterally and start with the on the side first at all times. Confrontation, patient seated. You want to be close enough, but not like invading their space. You want to be at eye level, and you need to cover the opposite eye that you're checking. So if you cover your left, you're going to cover your right as the doctor. And I'm hyperventilating here. You want to imagine almost a glass bowl around the patient's head, and you're going to go around. You're not going to go straight across. And the reason being is, if you're far away, the patient's going to be able to see that stimulus immediately. Make sense? One more time. Okay. Okay, relax. So there's a number of problems with this test. Number one, it's very qualitative. It's also taken a leap of faith that the doctor has untrammeled vision, and I sure as hell don't. Make sense? And additionally, it looks kind of silly. Question. Great question. What is the importance of the doctor covering the opposite eye? So the whole point is you're checking the patient's temporal field of vision versus your temporal field of vision, and your nasal field of vision against their nasal field of vision. Because if you cover the opposite eye, you're going to be seeing things and they're not. That's very important. I'm glad you brought that up. So what would this was essentially normal. So what would an abnormal test be? Okay, so blind spots in the patient vision, whether or not it's peripheral or central in nature. So what would peripheral vision loss look like? Well, it would look like the following. Okay, cover your left eye. I'm going to speak for Christine. Everybody got that? Don't say anything. There it is. Now it's gone. There it is. Now it's gone. So essentially, if this was a child, she has 20/20 tunnel vision, and that would be consistent with a condition called retinitis pigmentosa. Retinitis pigmentosa. Other causes of loss of peripheral fields include acute and open angle glaucoma. Now, what would a central blind spot or a central scotoma sound like on this test? I will show you. Cover your left eye, please. I will speak for Christine. Oh, there it is. Oh, now it's gone. Oh, there it is again. Oh, there's gone again. Oh, there it is. Oh, there it went away again. Oh, now I see it. Oh, now it's gone. Make sense? So what conditions could cause loss of central vision? Well, the biggest one is cataract. If there's an opacity right there in the pupil, that's going to obstruct the central field. Other conditions that most commonly are associated with central vision loss involve the central part of the retina, basically degeneration of the macula or retinal detachment. Makes sense? Not my favorite test in the world. Okay, I need a break, and I think you do too. So let's take, let's come back maybe 4:07. I don't know. Thank you. Okay, so I think we've come up with a solution to alleviate the Lou Gehrig echo. Can everybody hear me in 270? Can everybody hear me in 270? No? All right, well, maybe I just need to find a better place to put these microphones. Can everybody hear me on in 270? Okay. We'll put that one there. There's the echo again. All right, well, this is gonna have to do. We'll try and figure out a solution for that going forward, but we really need to continue here. Let me clean my hands. Christine, can I borrow you? So before I get to cardinal fields of gaze, have a seat. So before I get to cardinal fields of gaze, I want to discuss levator palpebrae muscle testing. So based on your anatomy, what is the main purpose of the levator palpebrae? What does it do? Uh-oh, I feel a pull coming on. Could you move over a little bit? How many of you think that the levator palpebrae muscle closes the eye? Dr. Singh, make sure everybody can't hear anything. Oh boy. How about now? All right, so I'm gonna have to put these down in order to actually physically do the test. So I only have two hands. I'll click them on my mask. Oh, it's gonna irritate my facial hair. All right, well, before we do this, I'm just gonna do my poll first. Levator palpebrae muscle. How many of you think it closes the eye? How many of you think it opens the eye? How many of you are still too scared to make a mistake? Don't be scared. Take a shot. Levator palpebrae opens the eye. So therefore, if we're going to check muscle testing of that muscle, we're going to resist the patient trying to open the eyes. And that's what we're going to do right now. Right, Christine, I'm Dr. Burdett. Could you remove your glasses? What I'm going to do is I'm going to have you close your eyes, and not now, but when you do, I'm going to take my thumb pads and I'm going to place them on your eyelids. And I want you to try and open your eyes against my pressure. Now you can close your eyes. Go ahead and open. I know you can't hear me. I put my microphones down. So, any pain with that? Okay. So let me tell you what, let me show you what I felt. I felt equal strength bilaterally, and I would grade it a 5 out of 5 if I had to quantify it. Is that, bless you, is that normal or abnormal? The answer is normal. So an abnormal test would be what? So an abnormal test would be weakening to the tune of less than 5 out of 5 on one side compared to the other. Or if in fact it was painful at all. Everyone keep in mind that as early as this weekend, I will be posting the lecture, the session of this. So there really is no need to film me real time. And that indicates what? Bless you, bless you, bless you. So in this case, that indicates that the levator palpebrae on the side that's weak is either neurologically weak or just simply irritated. So what nerve innervates the levator palpebrae muscle? Three what? Cranial nerve 3, oculomotor, that's correct. So in the scenario we did before, if there was left-sided oculomotor nerve damage, there will be loss, in this case on the left, there would be no direct reflex on the pupillary light reflexes. There would be no consensual reflex on the left, and there would be no accommodation on the left. And there would be weakened levator palpebrae on the left. For that to be the diagnosis, all 4 of those exam findings would have to be positive or abnormal. Does that make sense? That's why I'm teaching you a whole bunch of different tests for the oculomotor nerve. If in fact it was a textbook scenario, they all would be positive, including cardinal fields, which we're going to do next. Make sense? So let's talk about performance. Levator palpebrae, you want to make sure and have the patient close their eyes. You tell them to open them against your pressure. By all means, don't overpower them. This is probably the smallest muscle that you'll be evaluating in terms of a resisted muscle test. So there is such a thing as too much force. Just match their strength. And it's not Oedipus Rex here. Don't press too hard. Greek mythology, Sophocles gouged his eyes out. Sorry, I mentioned it. Any questions on levator palpebrae muscle test? I have it on pretty firm ground that this was not shown in your previous courses. So it's just one other additional procedure that we can do as long as it's safe. Any questions? All right, so let's move on to the cardinal fields of gaze. I think I'll use one of these microphones as whatever, have her focus on it. Cardinal fields. All right. Christine, Dr. Bodette, what I'm going to have you do is I'm going to put this microphone right here on your, I'm going to put this microphone right here in your face. So what I would like you to do is keep your head still, and with both of your eyes, I would like you to follow it, but don't move your head. Make sense? Any pain with any of this? Keep your head still. No pain with that. So again, that was pretty hard to see through the monitors. What I saw was both eyes moving symmetrically and not really staying motionless or kind of shaking a little bit. Is this a positive test or a negative test? The answer is negative. So an abnormal test would be where one eye, depending on which field you're in, stays either midline or is trying to contract, but basically is shaking a little bit. If it stays midline and doesn't move at all compared to the opposite eye, then that's what's called strabismus. S-T-R-A-B-ismus. If it tries to contract and it fatigues a little, this is what's called nystagmus, N-Y-S-tagmus. So all of those are positive findings indicating that the extraocular muscles are not functioning properly. Now, this is where you want to review which nerves innervate which one of the extraocular muscles. So which nerves innervate which muscles? Okay, so this is probably the best time to bring this up. You will never find a bigger proponent of mnemonic devices than myself, as long as you use the mnemonic device to correctly answer and solve the problem. For instance, for example, superior oblique muscle is innervated by trochlear nerve. That's the answer in part. The answer in part to which nerves innervate which cranial nerve, or which nerves innervate which muscles is not SO4, LR6, open parent, closed parent 3. You understand that? Don't just repeat the mnemonic, answer the question. So lateral rectus innervated by abducens nerve. All of the rest innervated by oculomotor. So the particular field in which you see nystagmus and strabismus will tell you which nerve might be affected, and more specifically, which muscle. Make sense? Let me give you a scenario. I see nystagmus and or strabismus in Christine's left eye in this position. Which muscle is the problem? In this case, left-sided lateral rectus. Short of individual pathology to that specific muscle, which is very unlikely, I'm thinking there's a problem or an irritation to the abducens nerve on the left. Does that make sense? What if I have whatever it is I'm having her focus on, in this case, my right microphone. What if I have it in this position and I see nystagmus and or strabismus in her right eye? Well, we know the problem's on the right, but in this case, it's the muscle that adducts the eyeball. So in this case, it would be the right-sided oculomotor nerve innervating medial rectus. Correct? And in that case, in a textbook scenario, I would expect to see nystagmus or strabismus in the patient's right eye in other places, namely up here, maybe down here. Okay. Well, so keep that in mind. And so let's talk about superior oblique. So if you look at Manner and Gatz, which is the first clinical neuroanatomy textbook, The way you check superior oblique muscle is by, and I'm quoting, depression of the medially rotated eyeball, depression of the medially rotated eyeball. So therefore, and the reason we check in that way is to do our best to remove the lateral rectus and the inferior rectus from the equation. So if that is correct, and it is, then, and there was a right-sided superior oblique problem due to a trochlear nerve irritation, the nystagmus and strabismus would be courtesy of when the right-sided eyeball is medially rotated and depressed. So therefore, in this position, let's do another one. If the left-sided trochlear nerve is irritated, then that's going to cause nystagmus or strabismus in the patient's left eye when it is medially rotated and depressed. So when is it medially rotated and depressed? Down here. I know it's a little bit counterintuitive and a lot confusing, but it doesn't make it incorrect. Now let's talk about performance because we're running out of time here and I think everybody wants to cool down. There's a couple things that you can do to screw this up. Number one, whatever it is you're going to have them focus on, you move too fast. I'm even getting a headache doing that. So you want to be close, but not close, not too close, and certainly not too far. And most importantly, well, let me ask it a different way. Do you have to do, and you saw me do an H pattern. Do you have to do an H pattern? The answer is no. So what could you do viably as an alternative to the H pattern? A star. Why a star? And how many points? 206. Please don't write that down. That was a joke. So if you do a star, it should be a 6-pointed star. It should go up and out in both directions. It should go out in both directions, and it should go down and out in both directions, so that you are effectively checking lateral rectus by going straight to the side and superior oblique on the opposite eye by going down and out. Everybody understand that? As much as Dr. Carlos and the IPA instructors try and explain this, I still know that there's always a little bit of confusion, so I always try and go very slow on this. Question. I think that was all I asked you to do, wasn't it? So let's spend the rest of the time running through these again. And if you have specific questions, we are here to help. Thanks. Hold on.